Welcome everyone to Solving Kid Cancer UK's Neuroblastoma Parent Symposium 2026 and the final webinar of its 6-part series. Today's session is titled Life After Treatment, Enhancing Quality of Life for Neuroblastoma Families. My name is Helen Pearson. I am Chief Nurse at Solving Kids Cancer UK, and it's my pleasure to be co-moderating this session with my colleague.
Hi everyone, my name is Hayley Blackwell. I'm the Family Support Coordinator at Solving Kids Cancer UK, and today Helen and I are joined by speakers Patel, who is a clinical nurse specialist in long-term follow-up at the Royal Marsden NHS Foundation Trust, Tiago Costa, who's a patient advocate and committee member of Childhood Cancer International Europe, and Dr. Gabriella Hyams, specialist clinical psychologist at the Royal Marsden NHS Foundation Trust. Before we begin, we'd like to draw your attention to the Q&A function at the bottom of the screen, where you can submit questions at any point during the session. There's also the option to submit questions anonymously and upvote questions you'd like to see answered. We'll come to questions after all presentations have concluded.
We'll now hand over to our first speaker, Em, who will talk us through how to understand and use children's end of treatment summaries for ongoing care and support.
So my name is Em. I am one of the clinical nurse specialists at the Royal Marsden Hospital. And as I was introduced, I'm one of the long-term follow-up clinical nurse specialists. So here at the Royal Marsden, patients are referred to or transferred to our team when they are 5 years of treatment. So we see it 6 years. So we would class all patients as being in complete remission, especially for neuroblastoma patients. Then there are no further scans. Which is a real positive but a really scary moment for families and especially for patients as they move further on. So in this session, it's going to be about who we see in long-term follow-up, what we mean by late effects, what we mean by long-term follow-up and what that means for all the different patients that we see, what treatment summaries are. Now, sometimes this might be a word or words that are familiar to some of you, may not be, but also what it means towards the end of seeing long-term follow-up, so that transition either into further care or discharge to self-supported management through the GP. So a quick kind of overview, as I'm sure most of us are aware, that over the last umpteen years, more and more young people, children and young adults, are surviving cancers, different cancers, and are surviving longer, which is why long-term follow-up is now a real vital part of that cancer journey. We know that approximately 60% of cancer survivors have one or more late effects of treatment. It's actually believed to be higher than this when we take into consideration psychosocial aspects. This more talks about physical aspects of late effects. Late effects does refer to anything that can happen soon after treatment or many years. So that's where the long-term part of my job comes into play. And it is completely dependent on the diagnosis, the genetics, the medical history, the type and intensity of the treatment. So we see all types of patients in our long-term follow-up clinics. So when we think about it, we will look at any of those long-term or late effects in terms of surgery, chemotherapy, radiotherapy. So in that is as well immunotherapy. And if patients have had high dose and then stem cell rescue, either themselves or if they're a bone marrow transplant. So as you can see here, there is a lot of potential late effects of treatment that we will then be thinking about and counselling patients and their families through. So as I said, and you can see by that graph, that more and more young people are now surviving. So back in 2008, which isn't that long ago in terms of the NHS, it was set up that all cancer treatment centres should be providing this long-term or late effects. So part of that was about providing this treatment summary and care plan, which I'll go through in further detail, making those individualised to each patient. So it's not just a kind of one document that is for everybody. We make sure that it is specific to each of our patients, that they have access to our specialised service or a specialised service at whichever treatment centre you are under, and that then we help patients and their families to move into their self-supported management, or if required into further adult late effect. So as you can see on this screen, it depends on what your level of care is that is required. So that comes down to, as you can see, if patients have had surgery alone or low risk chemotherapy, then we may only see patients every 1 to 3 years, and then we transition them to GP self-supported management. And then it goes up to level 3. So those who have had higher doses of radiotherapy, megatherapy, i.e. those who've had chemo, radio and surgery, or as I said, high doses of these things, and then they end up being seen often in a medic-led clinic. So as you can see, as I was talking about, these levels of care is down to what treatment the patient has received or the young person has received. So as you can see, if they've had surgery or low risk chemotherapy, then they're seen very infrequently and a transition to self-supported with the GP. And then it goes up to level 3. So those who've had higher doses of radiotherapy, or what's referred to as megatherapy. So that's multiple different modalities, so chemotherapy and or radiotherapy, or those who've had high doses of those chemotherapies. And these patients are often seen in medic-led clinics and are seen more frequently, but still only every 1 year, maybe every 2 years. And then often these patients are transferred or transitioned into an adult late effects service. Next slide, please, Helen. So in these clinics, as you can see, we discuss all sorts of aspects of late and long term. So how families, that whether it's the young person or parents or carers, to move beyond the treatment itself. We want our young people and our families to be living their best life, whatever that might be, and trying to put a close to what has happened to them previously, but also being mindful of any surveillance that might be required of that treatment. Talk to them about how to be the healthiest version of themselves moving forward. Where required, that peer-to-peer support. So there are lots of charities around the UK who provide support for other young people who've been through cancer treatment, which also brings then into the emotional well-being of the patient and the families, who are equally as important. And then we've talked about before the transitioning into further services. Next slide, please, Helen. So this is a rough example of what a treatment summary or end of treatment summary may look like. Different hospitals will look slightly differently, but this is a vague kind of plan of what ours looks like. So this is on our front sheet, and it's very medical. So it goes through who the patient is, what they had, how they were treated, and then anything that we are aware of that happened during treatment, anything that's currently going on with the patient, if they've got any psychosocial factors that anybody may need to be aware of, and obviously any genetic or familial factors. The point of this front page is that for the young person and the family, that if they see a new medical professional, then it's a really useful tool for them to give to that new medical professional so they can understand what has happened to that young person. There can often be some complicated words with the chemotherapies that we put in. Some of them have the doses. So these are bits of information that we would never expect that young person or family to always remember. Next slide. So here is an example of a completed end of treatment summary, or the front page of the treatment summary. So as you can see, it's got all the information that I was referring to. I'm sure for some families, they will remember all of this information, but these are useful for 20, 30, 40, 50 years down the line, so that information will be forgotten. Next slide. Then we have what's called a systems at risk and care plan. So this is the individualised care plan for the patient and the families. So as you can see, there is lots of headings on this around different body systems. So this is, we put in paragraphs that are specific to the treatment that the young person received, as well as any known side effects that we are aware of. So, for example, if a young person has received, say, doxorubicin, which is an anthracycline, then they would have their echocardiograms on there, and we would have all of those echocardiograms that they have had. So it's that useful document that if anything were to happen, that information can go to another medical professional so they know what has been going on with that patient from when we've seen them. It's also really useful to help guide those conversations, especially when we see younger patients in clinic first, as they then grow up and become teenagers and then young adults. So that information can change over time. We have some bits that are very worded towards children, and then we change that wording towards a teenager or a young adult so that they can understand more about what's happened to them, what that might mean for them in the future. As well as if they are transitioned to adult services, then there's bits of information about if they had any problems in the future. For example, if, especially with neuroblastoma patients with radiotherapy to the abdomen, that if bowel problems occur much later on down the line, then there are specific clinics that they can be referred to at the Marsden. So that kind of information is on there. Next slide, please. And then towards the end, we talk about any investigation. So this is the surveillance. So for most of these patients, not all of these are required, but as you can see, we would individualize this so that the patient and the family are aware of what's required moving on forwards. Next slide, please. And then that long list of websites and resources and places that our young people and families can go to for all kinds of different support, whether that is psychological, whether it is for exercise, or just general health and well-being for those patients. Next slide. The transition. There is a national transition programme called Ready, Steady, Go. So this was set up by Southampton, and this is something that we use at the Royal Marsden. So getting ready is at around about the age of 12 or 13. Steady is around kind of 15, 16. And then Go is around the age of 18. Now that is to move into adult services, which is slightly different for us at the Marsden. We have a TYA programme that goes until the age of 25. But it's to help that young person to understand what has happened to them. It gives them the opportunity to ask us any questions, or sometimes gets them to think about things that they may not have thought about previously, just so that we can help them if we do end up discharging at the age of 18, 19, 20, that they have all of the information that they need about what has happened and what it might mean for them in the future. So it's just a tool to help those conversations to move forward. So as you can see, that transition, so as I said, from up to 16 we have in paediatrics, and then we have our TYA up to the age of 25. Depending on that treatment that our young people have had, then, as I said, they will either be moved into self-supported management with the GP, or if they require further long-term follow-up services with the adult teams, then currently they can either go to Brighton or UCLH, but that will be a decision that is made alongside the family, but we can only keep patients until they are 25. Next slide. And then these are just some resources that we use here at the Marsden. Thank you.
Thanks so much, Em, for a really insightful presentation. We'd now like to invite our second speaker, Tiago, to talk about the right to be forgotten and how it can protect privacy and reduce barriers after childhood cancer.
Hello, everyone. Good afternoon. It's a pleasure to be here with you, and thank you for inviting me to speak about this important topic as well for the childhood cancer survivors. For the right to be forgotten, I'm going to tell you more about the perspective of a patient, a survivor, as in my case, a patient advocate, that I am in a national organization here in Portugal that is called Acreditar. It's a parents' organization for childhood cancer and young people with cancer as well, and also for my experience at Childhood Cancer International Europe as a committee member, and also a member of the survivors group in our global community as well, but specifically for the European perspective. So what is the right to be forgotten? So at very, very resume, it's a right that a person has to be like a normal consumer after having a past cancer diagnosis in this case, but can be other health aggravated disease or chronic disease, and for some reason is being again discriminated first for something that they did not have a clue of it, and it was not responsible for it because it was a disease in their childhood. And then second phase, because of a financial discrimination. But when applying for the cancer disease, it means that subject to a certain time limit and condition, a person is no longer required to disclose this past illness, the details of the illness, and in this context, such as mortgage applications, consumer credit, and related insurance policies as well. So no declaration required. Also, limitation on the health data use, pre-contract or post-contract. In this case of, for example, a life insurance, on the example of buying a house and asking for or applying for a bank loan, and also to prevent the discrimination of using this data from the survivors. And why does it matter for cancer survivors? So I think the aim is to bring the legislative measures that are now going on into the line of the medical progress that happens today. Because when science shows now today that the risk no longer justifies the penalization, the financial market should not also continue to treat the survivor as a forever hero. And for a survivor, sometimes this clinical recovery is not enough. And as we heard before in the presentation before, we have fortunately more and more survivors. And so this should not be like, again, another trouble, another challenges, and it feels like a marathon. So imagine a childhood cancer survivor as well, being sick at the very early stages of her or his life, or adolescence, and then years later after the disease, coming back again with some troubles that they will find out. It's like a marathon, like some obstacles that we'll find out only years before. And so it will be this recovery should be like a clear recovery with the best quality of life possible, and without any kind of financial or economic troubles or challenges, and discrimination in this case, or also any other kind of social discrimination and challenges as well. So the best quality of life possible. And for the childhood cancer survivors, as we know, for the context in Europe, we have the childhood cancer that has a survival rate of approximately 80% for all of the cancers. And there are around half a million of childhood cancer survivors in Europe as well. So again, we want to provide the best quality of life possible. But yet we know that there are some testimonies from survivors that they face some financial penalties years later after their finishing their treatment and after the disease. These are just some examples. So in the resume, they can have difficulty in obtaining some mortgage, any kind of mortgage, some requirements to take out an insurance on less favorable terms, the increased premiums, the exclusion of covers as well. So they want to buy a house, for example, but this process is becoming more it's becoming impossible sometimes as well, and more difficult. Also, the access to some consumer credits may become more expensive or impossible as well. And insurance, for example, linked to some kind of credit may be refused or restricted because insurance companies or banks are using the medical information from this ex-patient or this survivor now. And the person now feels like a double penalty, as I told you. So first the illness and then this kind of discrimination. So pediatric cancer must not be, or childhood cancer must not be like a lifelong financial, not become a lifelong financial burden as well. And without like this access to this kind of financial products, survivors find themselves unable to make some kind of decisions in adult life, So now they are not a children anymore or adolescent anymore in the future after the disease. And this, of course, has a direct impact on their independence, self-reliance, and also on their quality of life. So now a clear image of what is going on in Europe in terms of the existing measures to protect cancer survivors on the financial discrimination, not only for cancer survivors, other diseases as well. But here, when we talk about the cancer survivors, we have this map on this website that you can check it out, and you can click by any country that is here, and you will see the clear legislation that is going on, and it started with France in 2016. It was the first country to have like a legislation to implement the right to be forgotten for cancer survivors and other chronic health disease or aggravated health disease. And nowadays we have 9 countries already with these kind of legislative measures. Portugal, for example, it began in 2022. And then the others that don't have some of them, because there are other countries that, from some testimonies that we heard, there are some kind of insurance that the people that are born, they are born with this kind of insurance. So this insurance is enough to cover some kind of health details in their life, also and procedures, and also the kind of financial the access to financial services. At a certain point, when they want to update this kind of insurance that they have, they started to talk about some struggle as well. But for the other ones that don't have the legislative measure or law, they have like a kind of agreement between the state and the financial enterprises, companies, and the banks, and or also a code of conduct when they are trying maybe to reach the law, but they are still in the process to get it. And yeah, so that's also based on the testimonies and the feedback of some childhood cancer survivors and adolescent cancer survivors. And yeah, that's the image that we have now. Also from the world, there are some countries that are already trying to copy in a good way the laws that are going on in Europe. These ones, for example, from 5 to 7 or 8 years or 10. I will tell you more about the Portuguese case, but for more or less, these are the timelines after the treatment ends that people should wait to not to say the health information from the past to any insurance company or a bank or to apply to a financial service. So back to to Portugal legal journey. So it started at 2006, and what happened is that we found some general anti-discrimination framework. There was still no clear and specific for the right to be forgotten, but there was general protection for some kind of diseases and like the oncological disease. And so we looked for it and we saw what could we do better. And together with some survivors, with a survey, together with some lawyers as well, to find out what was what really was written in this law from 2006, we found out that we could have better based on the existing laws or the right to be forgotten that we saw that were becoming real. For example, France, the Belgium one, and the Netherlands one at the time. So in 2021, until 2021, we get and made some awareness campaign together with the people that had a little this experience of discrimination, not only on life insurance but also on health insurance, and together with our patient organization and with some members of the Portuguese Parliament, we got the law in 2021. Then this year we got some news because there were some things that were missing on on the law, and we were asking again to the deputies, and finally we were heard. So, but back to the 2021 law. In Portugal, we have the general timeline for 10 years for people who had the diagnosis after the 21 years old, not the pediatric age, the 18, but 21 years old. We look for it also in the French law and the Belgium law. It was not the pediatric, it was 21 years old. And so after 10 years old, this survivor can now apply for a financial service, a lower bank loan, and do a life insurance without telling the past to this company, her or his past health information. For people who have, for childhood cancer survivors, until 21 years old. When the diagnosis is until 21 years old, they only have to wait 5 years until. So this is until they do this application to a financial service. So the time it's okay for them because most of them have the disease in an early stage of their life. There is also another timeline is 2 years for a specific health, aggravated health disease, for example, diabetes, HIV, and hepatitis as well. And this is more based on the protocol, on the therapeutical protocol. This therapeutical protocol has been done 2 years ago until they can apply without telling any kind of information. Most of this information is not required on the pre-contract phase. Then after it, what happened was that some survivors that come to us, to our organization and give some testimony say that the agencies or the insurance companies were asking for a final resume note of like the end of treatment note from the doctor for them to proceed with the process. But we hope that with this next one, decree that I'm going to show you now, this will end and they will not ask for health information anymore for this kind. And with the law, the other law from 2021, nowadays on the life insurance survey, it appears all the law. So the people can choose all the law and not cancer disease or diabetes or HIV or hepatitis. So that was a big change. But what was missing? So in the first place, in the law, it says that there was or there should be an agreement between the states, the insurance companies, the patient organizations, the health professionals as well, organizations from the hospitals, from the clinics, and this agreement was never happened. Also, there was a reference table for less timelines for specific types of cancer that exists in Belgian law and also in the Belgian law. So in the French law and in the Belgian law, and it never happened as well. There was no such consumer information. So basically, it was us as a patient organization that gives this kind of information to the survivors. And also there was no identification of the entities that would be responsible to monitoring if the law is going well or not, or to get some kind of feedback or testimonies, and also to monitoring, especially the insurance companies, to see if they are doing it right or no. So we have this year some news. The Ministry of Culture and Youth, together with some Secretary of Finance Ministry, they came to our parents' house here in Lisbon, in Portugal, and they told us about this new decree law that they did in the beginning of this year to fulfill all of these challenges. And we are going to see if this will be going on or not in the right way. So we are trying also to get some feedback from survivors again, But also the current situation in Portugal is not very favorable because the prices of the houses are very high, but we are looking forward. And also in the laws that I showed you before, we don't have a clue and a real study about if the laws are going well or not. At least that is, I think, published for everyone to see. Before I get you to the patient advocacy work that we did, just to say that this is also a topic that is going on a European level, together with the Europe's Beating Cancer Plan that was presented in 2021 by the European Commission. And there was a specific recommendation on the quality of life chapter, but this European Code of Conduct was not yet published, and let's see if it's still going on, but it's referred along the Europe's Beating Cancer Plan. So to finish and tell you how we did it. So none of this would happen without the testimonies of survivors, of caregivers, together with our organization, to be in constant contact with the members of the parliament that made this legislation possible, and now this decree law. And only with the clear message, the right awareness campaign, to choose the person who will talk to before going to the members of the parliament, to see what it was the current legislation that was going on before, after the going also to the members, and to collect all the information that was happening in other countries. For example, we first come to collect the testimonies and the storytelling of our survivors that we have in our community and that are active in our organization. And this was what happened also in some of the other legislations that I show you about. So know your rights, for example, report what is not going well, or if there is any kind of discrimination, and find out if you don't are in a part of any kind of patient organization yet, to find out some of them that are more regional or national level, that you can then together come to the policy makers, for example. This is just a small example. If you are just an individual patient or caregiver, if you are a patient advocate, so you know more about the disease, or you are representing someone. If you imagine like a person from an organization, a patient organization that is representing someone and is telling or sharing the challenges that this community has. Or if you are a patient expert, more into the research, development, and you know more about some kind of disease, independent if you are a doctor, if you are a survivor, if you are a caregiver, but you have this kind of knowledge. And you have here a small YouTube video, so you can then see it. This is what we did in Acreditar here in Portugal. So first of all, we collect a survey. We did a survey and collect the answers of the survivors about discrimination on health and life insurance. Then we did, here in the middle, some awareness at our Portuguese media. And there was also 2 survivors that were very, very active with us, sharing their story and doing some kind of speeches in some conventions, and also in our community events. And then we went to the parliament. As you may see, it was in COVID time, that's why the masks. And then the law was approved. And nowadays, like in the last month, the ministry and the Secretary of Finance that came to our parents' house to announce the new decree law. Then for the CCI Europe, I invite you all to attend our global webinars, where we choose some topics about also not only about the advocacy, but patient and public involvement and engagement. And the speakers are also some experts on the topics, of course, but people from our community, from our kind of organization, non-profit organization, and parents organizations or survivors organizations of childhood cancer, or AYAS, adolescent and young adult cancer. Also, I advise you if you want to look more on the patient advocacy work and to do some trainings, the Weekend Academy. The present is a present to attend in terms of present academy, but like a weekend. But we have online courses as well, so you can do it by yourself, and they are really great as well. And if you are more into research and development, you can find here some courses, for example, about the patient advocacy or clinical trials, clinical research. You have here the Opati classroom online, and also the events that are in presence as well. So thank you very much for listening, and I'm available for all of your questions. Thank you.
Thank you, Tiago, for such an informative presentation. We will take questions very shortly. I can see the Q&A has been active, so we'll see you shortly.
We're now going to move into the Q&A discussion. So I'd like to invite all speakers back on the stage and welcome the wonderful parent advocate, Naomi Bentham, to the panel discussion. So I'm going to take the first question, which is for Em. So the Ready, Steady, Go, is that a national plan? You shared with the resources from Southampton Hospital, but wondered where to look for the information if parents are based elsewhere.
So yes, Southampton are the ones who designed Ready, Steady, Go. But it is a national initiative, but that means that each individual centre would have to take up that as their transition programme. I know that Southampton are kind of broadcasting it more and more, but you can Google Ready, Steady, Go or TIER, TIER, Ready, Steady, Go, Southampton Ready, Steady, Go, any of those things, and it will absolutely come up. You can print it yourself, you can have those discussions yourself, even if it's not brought up by your own clinical team, but it is readily available. And other centres might do other transition type conversations.
Brilliant, thanks, Em. And I wonder, Naomi, have you heard of the Ready, Steady, Go transition work?
No, I haven't actually, which is surprising. Obviously, Anya's 12 years out from us initially getting our treatment summary. And yeah, I think from talking to other parents, it's actually really intriguing that depending on which treatment centre you attend, you get completely different sort of treatment summaries or no treatment summaries. So it's interesting that there's not sort of a national sort of, policy that everybody gets the same information.
Thanks, Naomi.
Okay, next question we have for Tiago on the right to be forgotten. At what stage do we have or not have to disclose treatment for example, neuroblastoma, for things like insurance? So is it 10 years, 20 years? Do we have to disclose it for life? Does it invalidate insurance? Do you know that answer?
I think I am not the best one to answer, but I would like to ask if the insurance that is mentioned is for financial purposes or for health insurance, because it depends also. So the cases that I presented were for financial purposes, for accessing financial services after the disease. Yes.
Okay.
And it depends on the country and on the law that is going on.
Thank you. Naomi, do you have any examples where you've not known whether to disclose it? Has your child got any medical conditions? Technically, no, but it may need to be disclosed. It's a bit of a grey area, right?
It is, yeah. And the thing that we found is with travel insurance, that is the big issue that we found, that obviously we disclose everything about Anya's medical history, because obviously if we didn't, it would invalidate the travel insurance. However, we always have to go with travel insurance and tick the box that if there's anything related to neuroblastoma or the side effects, that it wouldn't be covered. And obviously, this is a bit of a worry that if we were in a situation that we had to make a claim and say it was something to do with her bowels or she even broke a leg, would travel insurers say, well, actually, this is linked to treatment and side effects? So it's always nerve-wracking getting insurance. And obviously, if we went for something that would cover side effects, you're talking a premium that would cost more than the holiday in itself. So it's always feels a bit of a gamble going on holiday with travel insurance. But I mean, what's the alternative? Never going and having those experiences that we, God, we want to give our kids more than ever.
Thank you.
Brilliant. And then Gabby, so a parent has said that they're not sure whether their child's sibling has been affected by the kind of upheaval with the neuroblastoma diagnosis. And obviously you touched on kind of siblings. What would you recommend if symptoms do persist? What would you recommend if symptoms do persist for siblings?
Yeah, absolutely. I think if you're ever worried, again, it sounds like this parent maybe is quite worried about their child, and if you do notice things that make you a bit concerned, always get it checked out. There's no harm in speaking to someone, talking it through with someone, whether that is, like I say, kind of your closest medical team, or asking for a referral to your local psychology team, or as I say, even schools. Schools have quite a lot of kind of access to support now. So they have like ELSA, depending on the age, there's like ELSA services, all kinds of things that a young person could get involved in as a potential space just to open up and talk through some things. And even if your young person was able to then open up in that space, and people were able to say, oh, actually, there are some concerns here about their brother or sister's kind of cancer journey, then an onward referral can happen. So it doesn't have to be now or never. It also doesn't have to be the perfect service. They can refer between. So I'd always say if you're ever worried, there's no harm in talking to someone, talking it through with someone, definitely.
Thanks, Gabby. And Naomi, I think Anya's got siblings. I don't know if you can talk about whether you noticed any impact during treatment kind of afterwards.
So she's got a younger brother, and he was actually born while we were, so Anya was the first child in the UK to go on DFMO. So we actually had him halfway through that treatment. So he came along after the sort of intensive period. But he has grown up attending the appointments, from a newborn who's coming to conferences from 6 weeks old. It has been part of his normal life. I would say the flip side with Noah, because it's been normal, I think he has a lot of empathy for everybody in all situations. He's very understanding. He is very level-headed. And when we've had medical crisis where Anya has had to be the centre of attention, he is very cool and calm. And I know that we've been lucky with that, that he is always been happy to take a backseat when it's a medical situation. But I echo the thoughts that if you are having those thoughts that you or the sibling might need extra support, definitely speak to somebody. It won't hurt anything just to talk and have that conversation.
Okay, one for Em. So your perspective is from the Marsden, but for a specialist bowel team, for a referral, if they wasn't treated at the Marsden, is that quite generic? Can they get a referral elsewhere?
So depending on where you live in the country, i.e. if you were London, then there's no reason why the Marsden, it's up at the Chelsea site, wouldn't accept. Sometimes these do come through GPs. This is obviously a very specialist team as well. So as far as I'm aware, they have accepted out of our area. But obviously, if you're based up in Scotland, then it would be going through your GP or your primary treatment centre to see where they would automatically refer through to. But there do tend to be super specialist clinics dotted around the country. But if not, then your CNS or previous consultant can always point you in the right direction.
And then Gabby, picking up on a little bit, you mentioned about kind of school support. One of the questions is around how can the school environment best support, and are there any training or resources for educators to be able to be informed and better equipped to support a child that's had neuroblastoma or cancer diagnosis?
Yeah, that's a really good question. Just thinking about resources, I know we have a couple of different resources, like CCLG has a couple of resources that certainly can apply to teachers and educational environments. I think lots of primary treatment centres will also, whether it's your CNS or if you do have psychology involved, or anyone, I'm sure will be more than happy to talk things through with your school as well, to be able to provide a bit of context, provide a bit of information. There can be a sense of, oh, you're off treatment, everything must be fine now. And I think it's really important to have that backup from your team that actually that's not the case, and to be able to share kind of things that school can expect, again, how they can support best. As I say, I think it's about having opportunities for talking. So I think whether it isn't an ELSA, or some schools have one-to-one kind of counselling available, or some have really close connections with local CAMS teams and things. again, it's just about having a space for your young people to feel like they can speak. And sometimes that will be with you within the family. And sometimes it's just much easier to talk to someone else who's outside of the whole unit. And they don't have to worry about upsetting anyone. They can say exactly how they feel and how unfair this whole thing has been for them, and not feel kind of worried about saying that. So I think purely about opportunities and spaces for talking. I think that's the best thing that schools can do, definitely.
Okay, Tiago, you've helpfully answered questions in the Q&A, but for the on-demand viewers, there was a question about the UK. So you helpfully said you wasn't sure, but you don't think there is no specific law on the right to be forgotten for cancer survivors in the UK for accessing financial services. So if there are any UK families or parents or just wonderful advocates sat at home thinking, what can we do here? What would your advice be?
Yes, of course. So first of all, if you are my opinion is if you are an individual patient advocate, to look for a regional or a national, regional, local or national patient organization. That because we usually say that together we are stronger in our survivors community, and that together we can see that my challenge that I have in the follow-up phase, so after the disease, is the same that a survivor from Spain or Italy or in the UK that may have as well. And so if we bring together, we can answer as a community and not as an individual. And then, for example, here we can go to the projects, European Union projects, and about cancer survivorship, and to tell them feedback as a community of survivors, and not of childhood cancer survivors or IS survivors as well. And I think that is the first point. And then to find out the right persons, to the first one, a person that can help you to reach the MEPs, for example, or the members of the parliament. And that person could be an organization, could be a patient organization that has already some advocacy work going on, and that you may join, or on a specific or volunteer work, or giving testimony and for that organization, so that the organization can then share and be the patient advocate for you to reach some of the decision makers. Yeah. And then if you want to join a global community or a European community, we're going to have our annual meeting this year in the UK, and it's every year is an opportunity for us to present some topics. And in our rooms are also health professionals that can listen to our challenges. So maybe in the UK there are events that you can attend as well, talking about survivorship, and when you can where you can give some kind of roundtable feedback, or to participate during these events or conferences as well.
Very helpful, thank you.
This one's probably for Em, but I think Tiago may be able to give kind of a European perspective. So the question is there a common approach throughout Europe for long-term monitoring? Feels like we rely on each clinic or individual doctor to dictate or not to take a particular follow-up plan. Shouldn't there be guidelines for particular exams in all countries? I don't know if Em, if you want to take that first.
Yes and no. So there is what's called the IGHG, so the International Guideline Harmonization Group, because that just rolls off the tongue. And they are the ones who look at any recommendations, any papers that have been released around what is best practice. And that is across Europe. Now, the rest of the world have similar, and kind of everybody works alongside each other. Obviously, it's still very niche, and we're still working out even what happens 15, 20, 30 years later. So we use the IGHG guidelines along with what the NHS can offer. So as an NHS, we'll look at that and then work out what we should or shouldn't be offering. And then again, each trust as to what we do or do not offer, what links there are. So there is still a lot of differences around the UK as to what surveillance people will or won't offer, and that unfortunately tends to come down to risk versus cost versus benefit, and what staff you have and what agreements you might have if there were other trusts involved. For example, the Marsden, see, we're a cancer specific, so we if alternative surveillance is required, so lung function tests or echocardiograms, then they're often carried out at other hospitals. So unfortunately, it's not as much as we would like every unit to be running on the same rules. That doesn't unfortunately happen, but we try, and there are guidelines that we each try to follow as best as we possibly can.
Thank you. Tiago, I don't know if you've got anything to add to that.
Yes, I agree with Dr. Patel. And also, we have the HGHG, but also there is now, for some years, an organization called PanCare. I don't know if you heard about that, is specific doing some research on the late effects. And there are now some brochures on late effects. And I think they are in English, of course, because they did it on the first in English. They are available on the PanCare website that you can use on your units as well, and to deliver to survivors and use in your work. And we are translating it to other languages. But this was also a procedure that was concluded with the help of survivors. So we had a 3 year project, European project, that it was called the European Youth Network of Cancer Survivors, and the project was called EU Net. And we get a community of young cancer survivors, and we visit some hospitals in Europe that had not the 100% best model of follow-up care, but each of them, the three of the ones that we visit in the Netherlands, Princeps Maxima, Vienna Hospital, and in Barcelona, the San Juan de Déu, they have a specific follow-up care, and we visit, and then we collect the feedback of all of the survivors, and this is published on our manual on quality of life that we have published on beatcancer.eu. That is the website of the project. And one of the parts was to give feedback on these brochures from PanCare on the late effects. So there was here the opportunity for survivors to be there on the hospitals. We ask questions directly to the doctors on how the long-term follow-up care was made, and on the written and articles and on the brochures, we gave our opinion as well. There was some working groups where survivors from all over Europe were working on this topic. And as we know, there is not in every country there is not a follow-up care consultation or structure or resources available, only in a few, and this is a challenge that we are working on from many years ago until now.
Okay, I have a question for Gabriella. So with all the will in the world, it's not that easy to just finish treatment and then just move on. So for those that it may be helpful to look back and also be involved with maybe cancer charities and kind of advocate later on in life, how can you protect yourself psychologically as maybe a teenager, young adult?
So just to check I've understood this correctly. So for those who are maybe taking on like an advocacy role almost in charities or within kind of the cancer world, I guess.
Yeah, so there's a comment about kind of how you can't just not look back and
No,
they still want to get involved. So
yeah,
psychologically, how do they navigate that?
Yeah, absolutely. And that really speaks to the idea that, I don't know, sometimes I wonder if my presentation is a little bit too much doom and gloom, but in lots of ways, we know there's a huge amount of growth that can come from adversity. And we certainly meet lots of young people, lots of parents who, as a result of their experience, certainly want to dive headfirst into charities in terms of fundraising, in terms of, young people who want to be kind of a medical professional when they're older, because of it's been so formative in terms of their experience. And Yeah, so I think that makes a lot of sense. In terms of protecting ourselves, I think that's a really important thing to also hold in mind. I speak to lots of families who have, for example, quite a big presence on maybe social media, again, to help other families, to connect with other families, to share experiences, share stories. And we talk about the importance of trying not to take on responsibility for everything, for everyone, for all those comments and things. The importance of allowing ourselves breaks and almost holidays from that experience as well. That of course it makes sense that's going to be a formative part of your identity, actually, for your family for a long time, if not forever. Um, and how you can make sure that you are allowing yourself a break from that as well, that you are allowing yourself space for life to also get bigger in other ways after treatment. So I think there's something about almost about pacing with some of that as well. That of course I think it's a beautiful thing to get stuck into lots of things like that if and when you feel ready to. But again, not having those shoulds or I should be fundraising or I should be involved in a charity or I should not. Again, whatever works for you is absolutely fine, and that will be different for every family who's here, who I speak to, who others kind of engage with. But knowing what kind of fits best for you and being able to lean into that.
Absolutely. Thank you.
Brilliant. And we've just got time for the last question, which is probably for Em. So with the end of treatment summaries being a medical document, is there a way that the child and young person can inform their plan in terms of age-related appropriateness and making this child-centred? So with those children who are diagnosed under, obviously, 5 years of age, and they will still be children as they go through the transition to long-term follow-up.
So it's not a medical document. This document is very much written for the children and family. I know I said that the front page is medical, as hopefully it showed on my presentation, which didn't really work very well. But it is medical in the sense that it lists the diagnosis, the treatment dates, the medications that were received, radiotherapy doses, any areas of interest that radiotherapy hit. So that's kind of as medical as it gets, so that, as I said, if you see a new medical professional, that can go to them and then they can look up that treatment protocol or understand what chemotherapies that young person might have had. The rest of the document is very much written for the patient and their family. So if it is a child, then we discuss it with, obviously, the family at first. So especially our under 10s, we discuss it with the family. And then as that young person moves through being a teenager, it might be that, say, we don't talk about fertility. That's not really an appropriate conversation to have at that time. But as they get older, we then start to talk about different sections with that family. But we will say to them, oh, well, you need to be healthy. What exercise are you doing? We need to do that. Those more pictures of your hearts. We do that every few years, and then move into kind of using those more medical terms of it's an echocardiogram. So we've worked long and hard. I'll probably be working on the last 2 years, and just making sure that actually those documents are patient friendly or family friendly. So as in the parents reading it at first, and then that young person understanding what that document is for them to move forward. So yeah. We feel it is, and our feedback from families is that actually they can understand it, and our young people, especially teenagers, can understand what's being written in there. We explain any medical terminology with what that actually means for them, and not just use all those medical words, so that they do understand. So, but yeah, hopefully, fingers crossed, it works.
Yeah, thanks, Em. Naomi, I wonder whether you have an end of treatment summary, and if so, have you found it useful?
We do, and obviously it was given to us quite a few years ago now. I wouldn't say it is the most useful document. It was kind of interesting to have a first glance at when we've given it. However, it didn't include everything that we have actually come across and other survivors have come across. So I think it's something that perhaps as there's more and more survivors, so there's more and more information of the different side effects that children can suffer from, I think it's almost worth revising almost every 5 years. And as the children get older, Anya's 15 now, there's different issues that we would be more relevant. So I think there's a way that it should be, I know it's an end of treatment summary, but I think it should be sort of updated, revisited, because our appointments with oncology in the after cure clinic now are very general, of like, how are you doing? Everything going good? Right, okay, see you in a year. And it feels like we're getting nothing from it. Whereas, Anya's side effects are actually impacting on her life, and it feels like we're almost like a tick box exercise. So I feel like the sort of end of treatment and that end of treatment summary doesn't actually fulfill anything further than that's almost a leaflet of like, thank you very much, this is where you're at, good luck. But that's just obviously our sort of experience.
Thanks, Naomi. It sounds like we might need to do some more kind of work around explaining those end of treatment summaries kind of nationally, and obviously everywhere works slightly differently. So, well, I just want to say that's all we've obviously got time for today, I'm afraid. And I really want to thank everyone who's joined us today and for all of your questions. Thank you to Em, Tiago, Dr. Himes, and also for your brilliant talks, and Naomi for participating in the panel. And once again, thank you to United Therapeutics, Norgine, Recordati Rare Diseases, and YMAB Therapeutics for so generously sponsoring this webinar series. I also want to take a moment to thank the people behind the scenes at Solving Kids Cancer, Claire Hislop, Georgina Clark, and many others who have made this webinar what it is, the unseen heroes in our charity. And United Therapeutics also wanted to ask us to share information about a child-focused resource that they've developed called Skivolo's World, which follows Skivolo, who is a character living with neuroblastoma. The series is designed to help children with childhood cancer and other medical challenges navigate their own unique journeys and to find comfort and understanding when they need it most. The slide we're sharing shows you how you can navigate to the series after the session.
Today marks the final webinar in our 6-part series, and over the past 6 weeks, we've been deeply grateful for all of our speakers, the experts, clinicians, and parent advocates for giving their time so generously to deliver these sessions. We hope the series has provided valuable information, support, and a sense of hope as you continue navigating yours and your child's journey, and serves as a reminder that as a wider community, we stand with you. We'd like to take this opportunity to remind you that Share for Life's Neuroblastoma webinar series continues monthly, and that their next session takes place on Monday, the 6th of April, with Dr. Brian Kushner on MSK clinical trials updates for neuroblastoma.
All of the webinars in our series have also been recorded, so you can return to them at any point whenever it feels helpful. Thank you so much for being with us, and we wish you a happy Easter. Thank you.